Yes.
Thank you very much, AIOS. Thank you, Dr. Preeti, for the opportunity. I can apologize slightly for the slight delay. So we're going to talk about the medical management of the two different diseases that we are dealing with, the PACD and the POAG. No financial interest. So one basic concept which needs to be kept in mind is that the difference is because of the different pathophysiology, as has been mentioned earlier. In PACD, the treatment is aimed at keeping the angle functional by preventing a pupillary block. And by and large, the PACD is a preventable disease. But one important caveat is that iridotomy, laser iridotomy, does not replace all the other options that we have. Whereas in POAG, the etiology is varied, the presentations are varied, and often the disease is common. But the similarity is that you have to have a target IOP for both the types of glaucoma. Now, for choosing the right medical treatment in both types of glaucoma, one has to understand what is the stage of disease that you're treating and also what is the target IOP that you have in mind. In POAG, the target IOP will depend upon whether the disease is mild, moderate, or severe, whereas in PACD, the treatment will depend upon whether it is a primary angle closure suspect, a primary angle closure, or a PACG. In PACD, the treatment will vary also depending upon whether it's an acute presentation or a chronic presentation. Let's look at each class of drugs and how they are used in the two types of glaucomas. The hyperosmotic agents like mannitol and glycerin, these are primarily used in acute stages. They reduce the reduce the osmotic gradient by increasing the blood osmolality. And they are more frequently used in the angle closure type, more frequently in the acute stage to break an attack. In POAG, sometimes they may be used in a situation like the Posner-Schwarzman syndrome, where you have acute rise in intraocular pressure. Also, they may be used before a filtering surgery. The second important drug is the pilocarpine, and this is one drug which is used in the two glaucomas in varied ways. It is a parasympathomimetic acting on the M3 receptor. It causes ciliary body contraction and miosis and iris thinning. The miosis helps in opening the angle and improve the drainage. But one important shortcoming is that the ciliary muscle contraction reduces the uveoscleral outflow. So in the acute, in the PACD, it can be used in the acute stage to relieve the pupillary block. In the chronic stage, it can be used as an adjunct therapy. Often it is used, or in fact, it is used routinely before doing an LPI. And pilocarpine in combination with other drugs like the carbonic anhydrase inhibitors, the timolol steroids are used to relieve the acute attacks. As far as it's used in open angle glaucoma in patients taking PG analog monotherapy, it has been reported that the addition of pilocarpine can significantly lower the IOP throughout the diurnal and nocturnal period, but it has no effect on the ocular perfusion pressure. And it has also been tried to relieve a reverse pupillary block in pigment dispersion syndrome. There are certain side effects. I won't go into the details of it, but certain contraindications, like if the mechanism of glaucoma is lenticular or retrolenticular, which may exaggerate the pupillary block, like phacomorphic glaucoma, malignant glaucoma, or aqueous misdirection syndrome, you should not use this. And also in certain cases of pseudoexfoliation where there may be zonular weakness. The second class of drugs is the beta blockers. These are basically the mechanism of action is blocking the sympathetic pathway, and thereby the sympathetic nerve endings in the ciliary epithelium, and thereby reducing the aqueous humor production. They are either the non-selective type or the selective type. In angle closure, it is one of the first line treatments, particularly in the acute stage as well as in the chronic type of glaucoma, angle closure glaucoma. And the reduction of 20 to 30% of IOP is possible within 1 hour. In the open angle type, it is again the first line of treatment, constitutes about 90% of the prescription is in India. It has better tolerability and affordability, and it is used as a monotherapy or as a fixed dose combination. The side effects like bronchospasm, heart rhythm abnormalities, and systemic hypotension have to be kept in mind. Then we come to the alpha agonist, the alpha 1A and alpha, it acts on alpha 1 and alpha 2 receptors. They cause vasoconstriction of the ciliary muscle and reduce the aqueous humor production. They also reduce the cyclic AMP and also reduce, but thereby reduce the aqueous humor production in the uveus and increase the uveoscleral outflow. In PACD, it may be used in the acute stage. It is supposed to reduce the IOP by about 26%. And a combination of brimonidine and brimonidine timolol is also quite effective, which causes miosis, but there is no ciliary muscle contraction. The effect of BTFC on the angle widening is reported to be a little more than that with pilocarpine, without the change in the anterior chamber depth. In the open angle type, the brimonidine is the first line of treatment, and it has some neuroprotective effect, so it may be used more frequently in the ocular hypertension type of POAG. It is quite well tolerated with relatively less side effects, and 2 concentrations are available. And again, the fixed dose combination has a complementary action in reducing the intraocular pressure, and the efficacy of the BTFC is supposed to be superior to administration of each drug independently. Apracolonidine, although not available in our country now, it is used to control the IOP spike after LPI, and it has a very short duration of action. Side effects like local congestion, stinging, photophobia are known, and also systemic effects like headache, bradycardia, and drowsiness are also known. Now, coming to the prostaglandin analog, they increase the uveoscleral outflow due to its effect on the matrix metalloproteinase and thereby change the extracellular matrix. There is no significant difference among the 4 PGA commercially available as far as effects is concerned. In PACG, its effect is independent of the amount of open angle, and it works even in eyes with no visible uveoscleral meshwork or a ciliary face. The prostaglandin analogs gain access through the yet unidentified pathway that possibly involves the iris, and that outflow of aqueous may involve something other than uveoscleral meshwork. The role of PGA in chronic angle closure glaucoma has been studied, and it is used as an adjunct treatment along with beta blockers after doing a LPI. But latanoprost is supposed to give greater IOP lowering efficacy than timolol in certain studies in the chronic variety of angle closure. And the IOP reduction reported is up to 30%, seen in 72% of the patients with PACG after LPI. In POAG, it is a first-line treatment, and the IOP reduction is 30% in majority of the patient, and the combination with timolol gives even better control. Side effects are these. I won't go to the details of this. The carbonic anhydrase inhibitors are again the class of drugs which are used to reduce the intraocular pressure in PACG, mainly to in the acute phase to reduce the IOP and open the angle to a certain extent. In POAG, they are used more as adjunctive therapy, and oral acetazolamide may be used in the perioperative period. So among all the class of drugs, it is found in meta-analysis that bimatoprost has the best efficacy as far as the effect in lowering the IOP. Coming to the summary, in PACG, the medical treatment is an adjunct to laser or surgery in PACG. The treatment protocol in PACG will depend upon the presentation. For acute PACG, the hyperosmotic agents, PAIs, cholinergics are most commonly used. LPI is important treatment in the angle closure. And in chronic phase, the topical PGA and topical beta blockers and alpha agonists are all there. For medical management of POAG, we have all the class of drugs available. And again, the stage of disease, life expectancy, and other risk factors have to be kept in mind. I end with this quote from the article by Dr. Rajul Parekh that the philosophy of glaucoma management should be preserve the visual function and quality of life, keeping in mind cost, side effects, treatment burden, follow-up schedule, and socioeconomic burden. Our aim is to treat the patient as whole so as to provide maximum benefit with minimal side effects. Thank you.